Hello, everybody. Good evening. I'm Dr. Nitiz Goyal, Senior Consultant Physician at Sony Hospital, Jaipur. I'm heading the Department of Non-Invasive Cardiology there. Today, our topic of discussion is pedal edema. So we will be discussing what the edema is, what are the causes of edema, and how it presents, and what can be done to resolve the edema. What is basically edema? Edema is the abnormal fluid accumulation in the interstitial space that exceeds the physiological capacity of lymphatic drainage. Interstitial fluid space is dependent on the hydrostatic and the oncotic pressure gradient across the capillaries and also the lymphatic drainage. So they are dependent on four main factors. That is capillary permeability, capillary hydrostatic pressure, capillary oncotic pressure, and the lymphatic drainage. As we have discussed the 4 points, now to elaborate, increased capillary permeability may be caused by the local causes are the cellulitis. It may cause increase in capillary permeability leading to edema. And the systemic causes may be some hypersensitivity reaction or septicemia. Capillary hydrostatic pressure can be increased by chronic venous insufficiency or compartment syndrome. And the systemic causes of increased capillary hydrostatic pressure are congestive cardiac failure, core pulmonale, that is right-sided heart failure, renal failure, chronic kidney disease, anemia. Decreased capillary oncotic pressure may be caused by protein deficit states like chronic liver disease, again related to kidney nephrotic syndrome, or some protein-losing enteropathy or malabsorption syndrome. Lymphatic obstruction can be caused by tumor, any trauma, radiation, or parasitic infection like filariasis. Now, the edema generalized edema is called as anasarca. It is mostly caused by fluid overload and hypoproteinemia. To evaluate the cause of edema, we need to evaluate with the following points: the site and distribution of edema. If the edema is unilateral in single lower limb, then it may be caused by deep vein thrombosis or cellulitis in that leg, or compartment syndrome, or maybe due to parasitic infestation such as filariasis. Bilateral pedal edema may be caused by congestive heart failure, anemia, chronic renal failure, or chronic liver disease. Now, edema can also be evaluated by the duration of the illness. If the edema appears acutely, then it may be caused by cellulitis or deep vein thrombosis or compartment syndrome. If the edema is chronic, it has been there for a longer duration, then it may be caused by systemic diseases, hypoproteinemic states, chronic venous insufficiency, and lymphedema. Other than that, if the edema is painful, then it may be due to deep vein thrombosis or cellulitis. If edema is painless on palpation, then it is due to systemic diseases or hypoproteinemic states or venous insufficiency. Now, variability of edema. The edema due to congestive heart failure usually aggravates. It is a dependent edema aggravated by stenting and improves with overnight limb elevation. If the edema, pedal edema, is caused by nephrotic syndrome, then it is a generalized edema, but it is very evident around the eyes and face in the morning, especially in the morning. In the chronic liver disease, edema is basically present in the form of ascites. Now, to evaluate the causes for edema, if it is cardiac edema, then patient presents with breathlessness on exertion, orthopnea, paroxysmal nocturnal dyspnea, chest pain, and palpitations. If the edema is due to kidney disease, then patient presents with oliguria, decreased urine output, and puffiness around the face. Other illnesses are there which may present with edema, such as hypothyroidism. But mostly in hypothyroidism, the edema is non-pitting edema. The patient presents with fatigue, weight gain, decreased appetite, excessive sleepiness, cold intolerance, constipation, and decreased menses in female patients. Edema may also occur due to obstructive sleep apnea. The patient may present with snoring at night, interrupted by episodes of apnea, excessive daytime sleepiness, daytime fatigue, and tiredness. Certain antihypertensive drugs that may lead to edema is clonidine, methyl dopa, alpha blockers, hydrolazine, calcium channel blockers such as amlodipine, as we have discussed, NSAIDs such as ibuprofen and diclofenac, certain hormones such as glucocorticoids, estrogens, progesterones, and certain oral anti-diabetic drugs such as pioglitazone and rosiglitazone. They lead to retention of fluid and development of pedal edema. Edema may also occur due to certain trauma or radiation that can lead to cellulitis and compartment syndrome. Examination of the patients in presented with pedal edema, we need to find out the distribution of edema, whether it is unilateral, which is caused by some local causes, or it is bilateral, predominantly caused by systemic illnesses, as we have discussed. The site of edema to be evaluated at bony prominences like medial malleolus and anterior aspect of tibia, sacrum site in the bedridden patients. Edema may present with tenderness also in cases of deep vein thrombosis, cellulitis, compartment syndrome, and edema due to systemic diseases and hypoproteinemic states are usually painless. Most of the patients with edema present with pitting edema, except in the cases of lymphedema and myxedema. As we have discussed, patient needs to undergo certain lab investigations to find out the cause of edema, such as the complete blood count, in which we can see anemia and clue to the cause of anemia. Anemia can lead to pedal edema. Renal function test shall be done, and along with the urine examination to find out the chronic kidney disease and nephrotic syndrome, liver function test for the evaluation of chronic liver disease, and along with serum total proteins and albumin to find out chronic liver disease, nephrotic syndrome, certain protein losing enteropathies, and malnutrition. Patients shall be subjected to complete lipid profile for nephrotic syndrome and coronary artery disease, and to evaluate the heart failure. Patients shall be subjected to chest X-ray, ECG, NT-proBNP, and echocardiography. For non-pitting edema and for evaluation of hypothyroidism, thyroid profile shall be done. D-dimers test shall be done to evaluate DVT as a cause of edema, pedal edema. USG abdomen shall be done to find out the echo texture of the liver to evaluate chronic liver disease, and bilateral kidneys to be seen for CKD, small size kidneys. Doppler study shall be done to rule out deep vein thrombosis and chronic venous insufficiency as a cause of edema. Echocardiography shall be done to find out the left ventricular functions in congestive heart failure, pulmonary artery pressure, and to rule out pulmonary hypertension in core pulmonary patients and obstructive sleep apnea. Now, the management of the pedal edema. In chronic kidney diseases, salt restriction and the fluid restriction shall be done. Patient shall be advised to take less than 5 grams of salt per day and less than 1.5 to 2 liters of the fluid per day, along with the usage of loop diuretics such as torsemide or furosemide can be given concurrently to reduce the edema. In cases of congestive heart failure, again, patient is advised to take less of salts and fluid, along with the usage of loop diuretics such as furosemide, along with spironolactone or eplerenone, in addition to beta blockers and ACE inhibitors. Chronic liver disease shall be managed with fluid and salt restriction and with the usage of diuretics. Albumin shall be given to correct the hyperproteinemic states. Obstructive sleep be managed with weight reduction and usage of CPAP, continuous positive airway pressure. Hypothyroidism shall be managed with the hormone replacement therapy with the use of thyroxine hormone. Cellulitis, edema due to cellulitis can be treated with limb elevation and empirical use of antibiotics. Edema due to deep vein thrombosis can be managed with anticoagulation therapy, long-term anticoagulation therapy, use of stockings, compression devices, and prophylactic anticoagulation. Venous insufficiency that causes edema can be managed with limb elevation, compression stockings, pneumatic compression devices. Thank you very much. So we have discussed the edema and the causes of edema and its evaluation and the management. Thank you.